Behind. How about that? Not so bad. So, I really appreciate the opportunity to chat with everybody today. I think by now I've been here about 2 months, and most of you have met me, and if not, I'm sorry. I can do a better job of introducing myself to everybody. I'm Jay Hauptman, and I am the new chief of neurosurgery, and I have the pleasure of chatting about probably the thing I am most passionate about in pediatric neurosurgery, which will be a bit of a review for our epileptology colleagues out there. You guys are more expert in this than I will ever be. But I was going to chat with you about a neurosurgeon's perspective on epilepsy surgery in children. I was going to keep this pretty informal, and I'm going to try to get a little bit of some of the research I've done over the years into the end of this, depending on time constraints. But I would love that if you have a question or concern or something you'd like to express or discuss, that you just interrupt me with, hey, Jay, hey, dude, yo, any of those would be acceptable. I think interrupters, so that we can discuss whatever your thoughts are. Um, let's get into it. So I have some disclosures. None of them are particularly relevant for this talk. And as always, giving a virtual talk is like screaming into the abyss. I feel like I'm at at the edge of the ocean, just screaming into the Pacific Ocean. So feel free to let me know you guys are awake, alive, caffeinated. If any of you are in distress, please let me know. Turn your camera on. We'll make sure help gets to you in a timely fashion. So one of the things that I love about epilepsy surgery as a neurosurgeon is that there are very few things in neurosurgery that are truly interdisciplinary, that are truly team sports. And so epilepsy surgery and tone management CP are probably the biggest ones. Craniofacial is a great interdisciplinary adventure with plastic surgery. But as far as the non-surgical interdisciplinary programs go, epilepsy is certainly a unique one. And so everything that I'm going to discuss in the next 45 minutes or so together, really, it's not me. Uh, Everything I show wouldn't be possible without a lot of people's hard work. We have our epileptologists, our neurologists, our neuropsychologists, anesthesiologists, radiologists, rehab physicians, our resident fellows and trainees, all of our therapists, all of our EEG techs, our nurses, our OR staff, our APPs. It really, really is a team sport. And these are the things I was planning on covering. We can talk about what is treatment refractory epilepsy, why we intervene surgically early, just something that I know a couple of us have written about extensively. I've written about quite a bit over the years. The etiologies encountered in children, what are our various surgical options and approaches, and this has changed quite a bit over the years. And our outcomes, as far as seizures, psychosocial outcomes, developmental outcomes, things that are particularly relevant in children. And so, from this sort of simple country pediatric neurosurgeon's perspective, I think about epilepsy in very simple terms. After a single unprovoked seizure, the risk of a second is between 40 and 52%. With two unprovoked non-febrile seizures, the chances by 4 years of having another is approximately 73%, but could be as high as 60 to 90% within that 95% confidence interval. And I, of course, lifted this definition from epilepsia. And for me, I think this really, lets at least neurosurgeons know this is how you get epilepsy in the EMR as a part of your past medical history. It's not a single seizure, but it's two unprovoked non-febrile seizures that get you that diagnosis of epilepsy. And that way we're all starting from the same foundation of understanding what seizures and epilepsy mean. Treatment-resistant epilepsy is where the surgeons start to get involved. And, if you think back into how we got to the definition of what treatment-resistant epilepsy is, it really was the hard work of Kwan and Brody. They did a very large natural history study. I'm fairly certain it was out of the NHS registry in Great Britain. It's been a while since I read that paper, but that's as I recall it. And what they found is, so what they do is they took all children who were diagnosed with epilepsy and just followed them, let their general neurologist manage their epilepsy as they would have had they not been in a study. And what they found is that once children reached two appropriately dosed and tolerated anti-seizure medicines, the addition of a third, a fourth, a fifth, and it really did not matter what that medicine was, whether it was the oldest on record phenobarbital or whether it was at the time one of the newest, it didn't change the likelihood of seizure freedom, which was less than 5%. So once you hit the two medication threshold, the likelihood of continuing to seize is 95% or greater. And if these seizures are associated with a structural lesion, so these are kids who are MRI positive, the likelihood of being medically refractory is nearly certain. It's not 100%, but it's nearly certain. That's based on work that's now over close to 20 years old. Which is wild because this is stuff that like I remember coming out during my residency that we were quoting, in papers and chapters we were writing. If medication trials are ineffectually continued beyond the 2 to 4 anti-seizure medicine ceiling, suboptimal seizure control can result in long-term, short-term and long-term neurological morbidity and even mortality. And that really is the fundamental driver behind offering and performing epilepsy surgery, both in adults and children. Now, we can get into this, but yeah, I did adult epilepsy surgery for a lot of years. The rationale is a little bit different in adults. These are older folk. The SUDEP risk is certainly a consideration, but not like it is in children. And a lot of folks who are adults come to epilepsy surgery to get a driver's license, or to get off disability and hold a job, or they want to get pregnant and become off ASMs completely. Those are big motivators for adult epilepsy surgery, whereas in children, the unacceptable neurological morbidity and mortality is much more of a spectrum. It's much larger in scope, and of course, really considers the SUDEP risk, which we can get into in a second. Like I was saying, this is from a 2006 paper by Spooner et al. Lesional cases tend to be highly refractory. If you see a lesional case, there's a new definition, what we call the one drug failure definition, which isn't even new anymore. That's been around for probably greater than 5 years. The new definition of medically refractory epilepsy in a child with a lesion is a one drug failure. The likelihood of a child being seizure free after trialing one appropriately dosed and tolerated anti-seizure medicine with an MRI positive lesion that is the likely culprit of the epilepsy, the likelihood of one medication stopping that epilepsy is near zero. Beyond that one medication trial is near zero. And this Kaplan-Meier curve is really a percent of non-intractable. It's not a survival curve. It's a non-intractable. You can see the lesion is the solid line, and that over time, very, very quickly, almost all these children become refractory by 10 to 15 years out. Almost 95% of these kids are refractory despite anti-seizure medicine trials. So the likelihood of, again, MRI positivity and intractability together are very, very high, hence the one drug failure definition. So again, treatment refractory epilepsy, beating a dead horse here, is a failure of adequate trials of two appropriately dosed and tolerated anti-seizure medicines to achieve sustained seizure freedom. It's a one drug failure if the MRI is positive. And when we say MRI is positive, we mean there's a putative culprit lesion for the epilepsy. It doesn't mean like there's a pineal cyst there. Or TRE malformation. When MRI positive means a lesion that we think is the culprit of the epilepsy. And just to be clear, what we call seizure free is a duration that's at least 3 times longer than the known interseizure interval prior to starting an intervention, or at least 12 months. So what I mean by that is if a child seizes every day, most will not consider them seizure-free till they've been seizure-free for a year. So it's not like 3 days seizure-free, major seizure-free. And for folks that have like an interseizure interval of 2 years or 3 years, which in the adult world was something I saw a lot of, that's 3 times the longest interseizure interval. So if you seize every 2 years, you need to be 6 years seizure free before you're labeled as seizure free, in both the literature and in clinical practice. Just some quick numbers here. The incidence of new onset seizures in children is relatively high. Approximately 4 in 1,000 children will have a new onset seizure, and over 2 years, about 10% of them will become treatment resistant. Even with great medical control over the first year, an additional 8% will become refractory within a year. So medically refractory epilepsy is not a small problem. You guys all know that. You see that in your practice, and it's really what helped develop pediatric epilepsy surgery into a more mature practice was the incidence of it. And so anywhere, depending on who you read, between 20 and 30% of new onset epilepsy in children will ultimately become refractory. And if it's lesional, nearly 100%. Why do we intervene with surgery early? I think for a long time, a lot of lay people have considered epilepsy a medical disease, one treated with medicine. Why would the neurosurgeons be interested in something that can be treated with medicine, even though we just explored that a lot of times medicine really isn't enough? Well, there are a couple things that have been very well described in the literature. For instance, in children with uncontrolled unilateral temporal lobe epilepsy, we know that there's over 60% of children affected with intellectual disability. We know that intractable epilepsy in the first 2 years of life is a significant factor for intellectual disability. That's been substantiated actually in multiple studies. We know that inadequately controlled epilepsy results in all the things that you guys see in clinic on the daily: impairments of cognition, language, social skills, communication, what we refer to as the epileptic encephalopathy. And I think in children, particularly relevant is that suboptimal seizure control really results in psychosocial outcomes that are unacceptable. Low rates of high school completion, low rates of employment, marriage, overall socioeconomic productivity, all these things are affected by the existence of epilepsy and medically refractory epilepsy. We know that early surgical intervention for intractable epilepsy results in improved IQ scores, improved developmental indices. Multiple studies have borne this out. And it's all about successful epilepsy surgery, improving the neurological outcome of these children. But perhaps the most compelling reason for epilepsy surgery is reducing seizure-related morbidity and mortality. And, for the last 8 years while I was up in Washington, I took care of a lot of children whose parents were very, very educated. Lots of children of Facebook and Amazon and Google employees, engineers, data scientists. I had a lot of parents in my practice who craved data and wanted to understand how to make a difficult decision for their child. And to me, it really actually boils down to SUDEP risk. SUDEP risk is the easiest way to distill an epilepsy surgery conversation to a very digestible tidbit. We know that children with refractory epilepsy have higher rates of mortality. And depending on who you read, the risk of SUDEP is anywhere between 0.5 and 1% annually and cumulative. That means, for instance, that a 10-year risk of SUDEP in a child who has medically refractory epilepsy can be as high as 10% mortality. And that's unacceptably high. I mean, name me another benign childhood disease that has a 10% risk of mortality over 10 years. Outside of cardiac disease, outside of the blood, the cancer and blood disorders, there are not many diseases that carry that kind of a high risk of mortality. And if you actually calculating the incidence of epilepsy, 4 in 1,000, children having new onset seizures, of which 20 to 30% can be refractory, that's actually a staggering number of children who are at an increased risk of death secondary to their what you would have considered previously to be a benign disease. And so for me, SUDEP risk is actually the great calculus for pediatric epilepsy surgery, and I'll tell you why. There is not a single operation that we offer in pediatric epilepsy surgery that has a risk of mortality or significant morbidity outside of the expected neurological sequelae of an operation that has more than 2 or 3%. And so what I tell parents a lot of times is when you're making a decision for your child to have epilepsy surgery, what you're really doing is you're packaging 2 years of SUDEP risk, and you're taking that package and absorbing it one time, the time of epilepsy surgery, in which there's a 2 to 3% risk of scary things happening. But that's the same as the risk of 1 or 2 years or 2 or 3 years of living with medically refractory epilepsy. And so the risk benefit calculus is actually very digestible and very easy to understand. SUDEP risk will outweigh surgical risk within 2 years of living with medical refractory epilepsy. And considering most children, I'll show you this in a second, have had medical refractory epilepsy for years before seeing an epilepsy neurosurgeon, it's actually a really easy calculus, I think, to absorb as a parent. Sandy Lamb, who visited us a couple weeks ago, a good friend of mine for a lot of years, she published what essentially was a meta-analysis where she looked at survival with a variety of different interventions for medically refractory epilepsy. It was an observational cohort study here in the United States, looking at medical therapy alone, surgical therapy, meaning surgery with an intent to cure, so resection, versus VNS. And I want to say she pulled claims data for this. And what she found essentially is that when you look at long-term survival, medical therapy alone has the worst long-term survival as far as the Kaplan-Meier, out to 9 to 20 years. And that both VNS and surgery have much higher rates of survival, likely you infer from this, likely related to their epilepsy. But you can see that surgical cohorts did the best, VNS cohorts did better, but medical therapy alone in children with, in pediatric patients with drug-resistant epilepsy, they fared the poorest. There was up to a 15 to 20% reduction in survival over the course of their childhood, 15 to 18 years. This is a survey I've shown in talks like this for over 15 or 16 years. This was published in Epilepsia by Harvey et al. And my mentor in residency was a guy named Gary Mathern, and I love showing this article because Epilepsia misspelled his name. You can see Barry Mathern instead of Gary Mathern. I like the show. I've had this slide for like a decade, showing Gary. And Gary was actually, for many of you on the call, you probably know, he was the editor-in-chief for Epilepsia for like 2 or 3 years. And this survey shows really how much room there is for improvement. Now, this is a 15-year-old survey, and I think we've come light years from this. But if you look on the left-hand side of the screen, the overwhelming majority of children with medically refractory epilepsy that ultimately come to an epilepsy center for a surgical evaluation, their onset of seizures is in their first 2 to 3 years of life. If you add that up, that's something like 65 plus, 60%, 65 plus percent of children have their onset of epilepsy in the first few years of life. However, if you look on the right side of the screen, that's how old they are when they get the surgery. And so while the majority of kids who ultimately are offered or referred to an epilepsy center for a surgical evaluation start seizing very early in life, they don't come to an epilepsy center until they're teenagers. And so there's a huge gap in between diagnosis of the epilepsy itself, then diagnosis of medical refractory epilepsy, then referral for a surgical evaluation, and then ultimately getting their surgery. I mean, these two curves should actually be congruent. They should be identical, but instead they're actually mirror opposites. They're like reflection of each other, which is a real problem. I think that we still need to tackle in this field. We've come a long way, but we still have a lot of work to do. And I think in part that's driven by, and you guys feel this every day, the relative shortages of pediatric neurological subspecialists in the country. Like, for instance, when I was in Seattle for a very long time, there were only 2 pediatric neurologists in the entire state of Montana. There's one in the west and one in the east. And if there are 2 pediatric neurologists serving the entire state of Montana, there's one in Billings, and then there's one, he's in Great Falls, Kalispell. There are more now, but this is what it was when I started there. for a state of 1.1 million people, how often is your child seeing their pediatric neurologist when there are only two in the entire state? So there's a, huge, I think, workforce shortage there that needs to be addressed too. Just to pivot a little bit, we'll talk about some etiologies we see in pediatric epilepsy surgery. This was the 2004 ILAE survey. I don't think much has changed since then. The overwhelming majority of lesional cases are cortical dysplasia. You can break that down by the variety in the spectrum of cortical dysplasia, from a lobar or a focal cortical dysplasia all the way to hemimegalencephaly. We've changed the way we grade cortical dysplasias over the years histologically, but fundamentally, really, there are two types of cortical dysplasia. There's a histologically more subtle type we call cortical dysplasia type 1, and then a histologically not subtle type at all, cortical dysplasia type 2, 3, and 4, infer the coincidence of other pathologies in addition to cortical dysplasia. But that's by far and away the most common thing that we see. Following cortical dysplasia are going to be your low-grade glial tumors, DNETs, gangliogliomas, glioneuronal tumors. Then we have atrophy or stroke, MCA stroke being probably the best representation of a case for hemispherectomy, though there are many others. Hippocampal sclerosis, which by far and away is the most common etiology you see in adult epilepsy surgery, is one of the least common that you see in pediatric epilepsy surgery. And then as you start getting further down, you get into the rarer entities. TS is something I saw a lot of in Seattle. We had a great TS clinic that Stephanie Randall and I helped direct. And hypothalamic hamartoma here is a center of excellence. Doctors Kerrigan and Wilfong and others have really developed a very, very strong institutional expertise in HH. So we see a fair amount of that here, which is seen very rarely in other centers. Sturge-Weber is something I've seen a lot of over the years, have done both TPOs and hemis for these. It's a great operation for this particular disorder. And then things like Rasmussen and other vascular etiologies. Just running through them real quick, like I alluded to, cortical dysplasia can be subtle on MRI. Sometimes it's positive, sometimes it's negative. When you look under the microscope, you can see balloon cells, cytomegalic interneurons, dyslamination, polarity that's off. The more severe cortical dysplasia tends to present at younger ages with higher seizure frequency and severity. It's typically extratemporal when it's severe and young in onset, but up to 50% of cases can be MR negative, can be subtle on EEG, which gives a little bit of a diagnostic dilemma. There are many times where it's MRI negative but histologically positive. PET scans are very, very helpful. Harry Chugani, who was at UCLA for a very long time, then went to Wayne State, and I think he's still there, but I'm not sure. Really, I think was one of the thought leaders in PET scan for diagnosis of MR negative cortical dysplasia, something that to this day has stood the test of time. And focal cortical dysplasia can be isolated, it can be frontal temporal, it can be the entire hemisphere, multi-lobes, all those things are possible. This is the new classification. Like I said, 1 and 2 are really the histological subtypes of cortical dysplasia, whereas type 3 is really associated with other lesions, whether it be hippocampal sclerosis, a low-grade tumor, vascular malformation, or injury. Low-grade glial tumors, DNETs, they can be on their own, they can be associated with cortical dysplasia. These are great candidates for surgical resection. A lot of times they can skip a complete phase 2, or rather they could skip a phase 2, they could even skip a very comprehensive epilepsy evaluation. Many of these can just go to surgery with MRI, EEG, and then surgical evaluation. And there are very high remission rates following resection. Other things that we see, perinatal infarcts, hippocampal sclerosis, which of course many people on the call here know. Hippocampal sclerosis really is the prototypical archetype for intervention with laser interstitial thermal therapy. The most amount of work in epilepsy surgery and lit has been done centered around mesial temporal sclerosis. We can certainly talk about that, but that was initially and still is, I think, probably the archetypal lesion to be ablated. in addition to HH, which I think has become sort of the standard of care. Sturge-Weber, for those of you who've never seen it, it's a port wine stain over the V1 distribution with pielangiomatous that can be half a hemisphere, an entire hemisphere. It's almost always unilateral, and over time, those kids will become hemiparetic to hemiplegic. It's either their pielangiomatous and dystrophic calcification over the hemisphere. If these children have hemispheric epilepsy, they're great candidates for hemispherotomy. I think for a long time, people really paused before operating on these kids because they were a little intimidated by the fact that the hemisphere was essentially one giant arteriovenous malformation. But I do feel strongly that these are very safe, very reasonable surgical cases with excellent, excellent outcomes. These can be safely done despite the fact that there's a large peel-angioma. I don't think the morbidity of surgery is any higher than any of the others that we do. Tuberous sclerosis is a disease that's near and dear to my heart. That's what I spent my PhD studying. We all know that there are mutations at TSC1 and TSC2 that can cause this disease. Sometimes it's known to exist in families. Sometimes it can appear in all kinds of form-fruste, radiographic presentations. But it really is a heterogeneous disease. It's not as simple as we would think just looking at it in the textbook. Seizures can be focal, multifocal. They can be very treatment resistant. A lot of these kids have intellectual disability early on. There's always a question of whether it's the seizures that are causing the intellectual disability or the intellectual disability is inherent to the genetic disease itself. Sometimes there can be several tubers, multifocal EEGs, but surgery sometimes can be very, very successful, even in that setting, from resection of just a single cortical tuber. And phase 2 stereoelectroencephalography is actually transformative in these cases. You can do staged resection or ablation. You can do staged RFA. There's like all kinds of different options in TS. And I think that disease in particular, I think is very, very, very amenable to stereo EEG followed by resection or ablation. And sometimes you just do a staged approach where you resect one, let them cool off for a bit, bring them back, repeat an evaluation, do another PET, do a SPECT, see if you can find another tuber that's causing it. Rasmussen's encephalitis is a relatively rare disease that I've probably seen on average 1 to 2 times a year. And it is essentially what we think is an autoimmune disease that progressively involves almost always unilateral. There's debate about whether bilateral Rasmussen's exists, and there are people who certainly have reported it. But generally, we think of it as a unilateral disease that leads to progressive hemiparesis and intractable epilepsy. You can try steroids, you can try IgG, plasmapheresis. Many of the times, it's just temporary and can hold off surgery for a little bit, but hemispherectomy really is the only known cure for their epilepsy. Sometimes we have these sort of less prototypical radiographic presentations of Rasmussen's, and so it's not uncommon to have to do a biopsy of areas of flare abnormality or atrophy to prove that they have Rasmussen's before doing a hemispherectomy. HH is something that we talk about a lot in our epilepsy conference because we have such expertise. Here, they generally arise from the tuberous area between the mammillary bodies and the optic chiasm. The sort of prototypical seizure that we all think of with HH is gelastic seizure, which is laughter without mirth. Many of these kids are affected by central precocious puberty. I was sharing this in epilepsy conference a couple weeks ago, but I had gone maybe like 6 or 7 years ago. There was a Hope for Hypothalamic Hamartoma conference in Washington, D.C., led by Bill Gaillard over at Children's National. And we had parents at this conference, and they had distributed some surveys. And it's interesting, if you ask parents what their biggest concern is with HH, it's behavioral. Like by far and away, it was like number 1, 2, and 3 on the priority list were the rage attacks, or the sort of fits of rage that are very common in HH, because a lot of these kids have hypothalamic dysfunction. So they're big. They're large children. Many of them have hypothalamic obesity, and they have a lot of behavioral issues, and some of their parents found them difficult to manage, and felt threatened at times. And HH is an interesting entity because in the course of my career, starting from when I was in training to today, it's been actually a huge change in the way we manage them. When I was first exposed to HH early on in residency, they were almost universally treated with open surgery from an interhemispheric transcallosal approach where you would either resect or disconnect the HH from the third ventricular wall. Then we started playing with endoscopes and doing it through a transventricular endoscopic approach. Then the Europeans were describing doing radiofrequency ablation, the Japanese as well, though that was really restricted to a lot of the European and Japanese literature. Then Jean Régis in France described doing stereotactic radiosurgery with pretty high seizure remission rates, but you are radiating children. That fell into favor for a while. But in the last decade, I would say laser interstitial thermal therapy has really emerged front and center as the primary treatment modality for HH. And I haven't done an open surgery on an HH in a very long time. And that's because lead has really become the standard of care for these. Other etiologies that you see not infrequently in epilepsy surgery, conference polymicrogyria is a very tricky disease. Many times it's bilateral, the epilepsy. Many times it's bilateral radiographically, making it challenging to localize. Stereo EEG can be helpful. RNS can be very, very helpful in these cases. There are rare cases where you can do a unilateral operation and render them seizure-free, but anytime you see PNG in the back of your mind, you're always wondering whether it's a bilateral disease. Landau-Kleffner, which is an epileptic aphasia, which actually came up in conference the other day because we were talking about doing multiple subfield transections, which MST was one of the treatment modalities surgical that we used to use for Landau-Kleffner. Now it really depends on the age of the child, and sometimes in young children you can do a resection. Sometimes RNS can be very, very helpful in these cases. Hemimegalencephaly is a prototypical hemispherectomy candidate. It's really just a large hemispheric cortical dysplasia, and can cause very, very refractory epilepsy early on in life. There can be a genetic component. We've identified a lot of kids who are on the PI3K mTOR spectrum. DEPTOR is another emerging another emerging gene that's been implicated. Well, DEPTOR is the enzyme, but DEP3CD, which is the gene that encodes the DEPTOR enzyme, has been implicated as a genetic molecular etiology of hemimegalencephaly. So those are some of the etiologies, surgical evaluation and approaches. Of course, many of you know that this is, again, a team sport. We look at a variety of different ways to build a case against an area of the brain that we think is causing the epilepsy. And when I'm giving this talk to parent groups, I always refer to that movie, My Cousin Vinny. I'm just curious, I'm going to make you interact with me for a second, but can you guys use that hand raise thing if you've seen the movie My Cousin Vinny? Can you guys hit that hand raise thing? Dr. Chapman, thank you. Dr. Lewis, Dr. Fox, Dr. Friedman, Dr. Crew, I'm going to shout you all. Thanks, guys. So My Cousin Vinny is a movie of my childhood. It's just an epic movie. Thanks, Jenny. It's an epic movie in which Ralph Macchio, the Karate Kid, is driving through the Deep South with his buddy. They were, I think, in school at the time. They were at the wrong place at the wrong time. They had left a convenience store right before someone came in and robbed the convenience store and shot the clerk. And Joe Pesci, My Cousin Vinny, who's, let's just say, a Hollywood upstairs backroom attorney, like Dr. Nick from The Simpsons, was called in to get them exonerated because they were being charged with murder. And the way he built his case was through circumstantial evidence. And building a case for epilepsy surgery is identical to the way Joe Pesci's character had to get his cousin, Ralph Macchio, and his buddy acquitted. They had to use a series of circumstantial evidence, including, tire prints in the mud and eyewitnesses that really didn't see the crime as it occurred and all these things. And that's an epilepsy evaluation. There's just not one test really that can pinpoint exactly what zip code, what house, what street address. These seizures are sitting on the couch at 7300 Thomas Road, Phoenix, Arizona. And so trying to localize the epilepsy to a very, very specific brain region can be very challenging. We know this because we're doing this every single week. So we use a variety of different tools, both invasive and non-invasive. Our non-invasive tools are our structural MRIs, our functional MRIs, our non-invasive electrophysiology, interictal EEG, video EEG, high density array, MSI, magnetic source imaging, MEG. All of these are tools in the toolkit. Sometimes we have to go to invasive methods like stereo EEG, grid placement. And of course, our neuropsychologists are incredibly key in identifying areas of brain dysfunction and helping us track our outcomes. So of course, these are all pictorial representatives of a variety of different things we use to localize epilepsy, video electroencephalography, our neuropsychologists identifying areas of brain dysfunction, both for the purposes of implicating brain regions that could be the cause of the epilepsy, but also allowing us to track how we're doing. How are our kids developing cognitively during their operative recovery? High resolution MRI, which at one point in my career was 1.5T, now it's 3T. At some point, it's probably going to be 7T. I know the Mayo Clinic over in Scottsdale has a 7T MRI, and they're starting to explore using it in adult epilepsy patients, and we might even be sending some kids over there for 7T MRI. PET, like we talked about with Harry Chigani, PET has really transformed our ability to identify MR subtle or MRI negative cortical dysplasias. We look for interictal hypometabolism in children that have very high seizure frequency. You can actually look for ictal hypermetabolism because they're seizing during the study. SPECT is something that we used at UCLA on occasion, and also in Washington. We didn't use it at Seattle Children's, but we did use it at Harborview. SPECT can be very, very helpful. It's an ictal study. It requires the administration of a radionuclide right at the time of seizure so that you identify the seizure, inject, and scan. But of course, as you could imagine, that requires some logistical and technical considerations, particularly in children. So, Harborview, where we did ictal SPECT, had really closed guardrails as to how young we were allowed to do it in, and how frequently they had to seize in order to qualify for getting an ictal SPECT. Surgical approaches, this has undergone a lot of change, in my career. There was a time where the only invasive option was grids. We were doing stereo G at UCLA my entire residency in adults, but we were doing it, the French method, which was with the Lexel frame, and that was a very, very, very long and painful operation for the surgeon. You were talking about 8 hours to do bilateral stereo electroencephalography in an adult, and never really took off in children. Grids are a tried and true methodology. They give you a lot of spatial coverage in high density, but they don't, but it's really hard to do bilateral subdural grids. You have to do burr holes. You can't really do large exposures because there's a lot of morbidity associated with that. So stereo EEG really transform our ability to do really, really spatially wide recordings, bitemporal, bilateral frontotemporal, bilateral whole hemispheric. You can do all those things with stereo electroencephalography. The downside being the density of coverage is a little bit lower because you're using depth electrodes instead of surface grids. However, as you guys all know, anywhere between 30 and 50% of the brain surface area is folded in convolutions and is in sulci. And the truth is that you probably get better coverage of the sulcus with a depth electrode than you ever will with a grid electrode because you're at the surface and the depth of the sulcus is here. Resections can be anywhere from lobar all the way up to hemispherotomy, hemispherectomy. Palliative disconnection techniques, corpus callosum has been around since the 60s, but the way we do it has changed. Very few times are we doing it open anymore. The majority of the time we're doing this with a laser because of the morbidity is a bit lower. And it's really just a much cuter operation with no risk of hydrocephalus. We're very, very low risk of hydrocephalus. And then neuromodulation, which for a long time, as Angus can attest to, was VNS. The VNS was the only neuromodulation option we had. It really is the only one still FDA labeled in children. It's been around for a very long time. now the brain surgery, but DVS and RNS have emerged over the last 5 years as a very, very influential neuromodulation options that are really being talked about and explored a great deal. Stereoelectroencephalography, like I said early on in my residency with Itzhak Fried, we were doing it the French way, which was using the Lexel frame. It was an all-day operation, and like I said, just very painful for the surgeon. Now we do with a robot, what we call robotic assisted surgery. For a long time here it was being done with the Stealth Auto Guide. Now we'll be doing it with the Rosa robot, but they really all just do the same thing, which is a robotic arm tells you where to go so that you can place a depth electrode with a high degree of accuracy in three-dimensional stereotactic space. And we almost entirely do this in an image-guided approach, which is you identify in an MRI where you want to place the electrode. You fuse that MRI with the CT scan that's performed in real time, usually with some sort of a fiducial. You fuse the MRI with the CT, and then you're able to essentially place these electrodes where you would have wanted them on an MRI, but you're actually directly using the CT. It's just that the CT is fused with the MRI for localization. Subdural grid electrodes, we still do them. It's a bigger surgery, requires a bigger incision. It's a little more headache involved for the patient. But I still think there's very much a role for subdural grids, particularly with regards to mapping eloquent regions. I think we're getting better at that with stereo EEG, but there's still some limitations there. And so, subdural grid electrodes can be very helpful. One of the downsides of subdural grid electrodes is no one's really enthusiastic about doing them in very young children for a lot of different reasons. So stereo EEG is a better choice for young children in general. Temporal lobectomy is by far and away the best studied operation in lesional epilepsy surgery. Sam Wiebe, I mean, this study is now 23 years old, showing the superiority of temporal lobectomy in the medical therapy and refractory unilateral temporal lobe epilepsy. And it's not a subtle difference. Extratemporal resections are a mainstay of pediatric epilepsy surgery because the majority of surgical epilepsy we see in children is extratemporal. Awake mapping, awake mapping is something that we did a lot of both in my residency and my fellowship, and then in my prior existence in Washington. What I think for a long time has been reserved for adult patients can be done safely and effectively in children. The youngest child I've ever done an awake surgery on was 8, who had a tumor in his Broca's region, and we were able to resect it without interrupting his expressive language. There is no more clear gold standard to functional mapping than awake surgery. Everything else you do can be good, but not as good as awake mapping. And you don't necessarily need awake mapping for everything. For sensory motor region surgery, I think like MEPs, SSCP phase reversals can be very, very helpful, or direct cortical stim with a child asleep can be very, very helpful. So I think for awake surgery for children, motor and sensory motor mapping is a little more gray as to how often I think that needs to be done. But for language mapping and any other higher order cognitive function mapping, and this is a picture of Kira Iaconetti, who got, I think, internet famous for having a brain surgery in which her auditory cortex was mapped. She is an aspiring Broadway singer. She had a low-grade glial neoplasm in her Heschel's gyrus, and she was actually having musicogenic events, which is the only time in my career I've operated on a child with musicogenic epilepsy. And so we did a lot of really cool things with her. We developed some new functional MRI paradigms where we tested tonality, pitch, musical prosody, in the functional MRI using bolt signal, and we got some really interesting areas of activation. And then we did an awake surgery with her singing because it was just so important to her to preserve her musical audition. And so it was a very successful case. And like I said, she became internet, rightfully so, became internet famous for it. She's an amazing young girl. Still to this day, seizure free, doing great, performing locally in Bellingham, Washington. Last year, I got an invitation for her to be in their rendition of Elves. It was fantastic. I don't have to teach you guys about lit. You've been doing it for a very long time. This is what it looks like. Mesiotemporal sclerosis, by far and away the most prototypical, and HH by being, I think, the second most commonly prototypical reason to do lit. Hemisterectomy, many of you have seen it. Many of you have referred for it. It's used for catastrophic unilateral hemispheric epilepsy, though there are even exceptions to that. I've had children over the years that have bilateral disease. However, one side is causing clinical epilepsy more so than the other, and we will consider palliative hemisterotomy in those conditions. Rasmussen's, whole hemispheric cortical dysplasia, hemimegalencephaly, Sturge-Weber, hemispheric migrational abnormalities, MCA stroke, post-trauma. There's a lot of really good indications for hemisterectomy. There was a scale that was created a bunch of years ago called the HOP scale. Not a whole lot of people use it because I think it's fairly intuitive. What it showed us is that MCA infarcts do the best, and hemimegalencephalies have probably a slightly higher rate of recurrence than everyone else. But it's also sort of common sense because an MCA infarct is a one-time perinatal acquired event, whereas hemimegalencephaly is genetic, and up to 25% or more of kids with hemimegalencephaly likely have involvement of the contralateral hemisphere. Hemi has undergone a lot of technical transformation over the years. For a long time, people were doing anatomics in which you physically remove the entire hemisphere. We've moved away from that for the most part because of the unacceptable rates postoperatively of superficial hemosiderosis, which causes a dementia-like picture, almost like chronic subdural hematomas. The Adams modification, which we actually did on the rare cases that we did anatomic hemisterectomies, which is where you plicate the dura so that you can close off the subdural space to mitigate the risk of chronic subdural hematoma formation. That's what that's showing on the left side. But most people by far and away do the perinsular hemisterotomy, which is above and below the insula through the opercula, resecting the insula as a block, doing a transventricular callosotomy. We'll over all that in a second. And perhaps I would say the newest way, but definitely not universally adopted, is the vertical parasagittal technique, which was originally described by Olivier Delalande, who I had the privilege of meeting twice as a resident. He's a French epilepsy neurosurgeon, same Delalande that HH classification is named after. And he was a super interesting guy, and he described doing essentially a hemisterotomy from a vertical parasagittal approach, which while intuitively makes sense to me, the anatomy is less clear. I think the visualization isn't as good, and the reach from the parasagittal approach down to the temporal lobe is quite long. And I'm not super convinced that that's the superior hemisterotomy technique. Some people have described doing it with an endoscope, which I think for those of you who saw Sandy's lecture, Sandy is one of those people who've described in Polish doing it with an endoscope. We sort of talked about the variety of hemisterotomy approaches. And the other thing I'd mention about hemisterotomy is that for a functional hemisterectomy, there are 6 key disconnections: corona radiata, basofrontal, insular opercular, parietal occipital, mesial temporal, and the transventricular callosotomy. And it's those 6 disconnections. I hope I just named 6, but there's those 6 disconnections are really the key to doing technically sufficient functional hemisterotomy so that you mitigate the risk of seizure recurrence. Hemisterotomy is, in all truth, the most successful operation that we have for epilepsy. 70 to 90% seizure freedom rates. You really don't get higher than a hemisterectomy, but the key to hemisterectomy is choosing the right patient for it. Callosotomy has been around for a lot of years. It's really, really helpful for atonic seizures. Some have proposed doing it for primary generalized or rapid secondary generalization. It's really not it's not as effective for seizure types outside of atonics. I think most could agree with that statement. Lennox-Gastaut, I think, is the prototypical disease that we use calisotomy for. We ask that patients referred for calisotomy have neurological and intellectual ability sufficient for recovery. Though I think even with LIT, we've widened our berth for patients that we're willing to accept for consideration for calisotomy. There's a 70+% improvement in atonic seizures, up to 50% if they're atonic predominant, can be seizure-free. Motor complex partial seizures are less successfully treated with calisotomy, and we all talk about the acute disconnection syndrome, which is likely related to the posterior body and splenium disconnection, which can result in mutism, left-sided hemiparesis, apraxia, urinary incontinence, and it usually improves in a few weeks. Some of it is likely from the open approach retraction on the frontal parietal lobes medially. But even so, even with laser calisotomy, you can see acute disconnection. And so you definitely want to warn families about that as a risk. It almost always gets better. I haven't really seen a case where it doesn't. The neuromodulation, which I think we're going to talk about in epilepsy conference even a little bit today, is front and center in the discussion for epilepsy surgery, VNS being sort of the long-standing neuromodulation option, closed loop neuromodulation being RNS, open loop being DBS. We can talk about this more at the end if you guys have thoughts on it. People are talking about transcutaneous VNS. The Germans have a device for transcutaneous VNS that has not been adopted in the US yet. Don't know if it will. RTMS is out there, is being used therapeutically for epilepsy. It's mainly in the research paradigm, but it's certainly being used in the psychiatric disorders. And hopefully in the next year, we're going to have a TMS machine here. Transcranial direct current stimulation is not something I have really any experience in at all. I've only read about it. And I think there's going to be a lot of work done in closed loop RNS DBS in the next decade, especially with the help of AI. It's never a neurosurgeon speaking if they don't gratuitously cite themselves in some way. So I just I had to cite a paper that I wrote as a resident because I thought, not because I think it's a great paper scientifically, but because it has cool pictures of how we place a VNS, which is why I put it up here. Like I said, DBS is thalamic DBS. The Santee trial introduced the idea of thalamic DBS now over 15 years ago in the anterior nucleus, but people have been placing DBS in the thalamus since the late 80s, early 90s. The Velasco's in Mexico City since 92, 93 have published series of patients, pediatric patients with central median DBS. Responsive neurostimulation has been on the scene for about a decade. Really was originally intended for neocortical foci, bitemporal being the most prototypical, but now its use has been expanded to, neocortical thalamic or bithalamic, and we can certainly talk about it, but I think there's a lot of excitement around it because it's closed loop. To me, the most important message here is that neuromodulation helps. Neuromodulation reduces seizures significantly and can be synergistic with VNS. So having VNS and still having seizures would make you a great candidate for any of the other neuromodulation therapies. And the most compelling thing I think is less is less. Less seizures are better. Less seizures reduce SUDEP risk. And I'll just end with outcomes. Outcomes are good. 65 to 80% of children can be seizure-free after surgery. That number is heavily influenced by etiology, type of surgery, how convinced we are in focality related to our localizations. A lot that goes into it. MRI positive, MRI negative, temporal, extratemporal. We know that if you're seizure-free early after surgery, it's the best predictor for being seizure-free later after surgery. There was a paper that we published at UCLA now a bunch of years ago showing that there is a late recurrence of epilepsy, but it's small. It's less than 15%. And up to 50% of children can be taken off their meds if they're seizure-free after surgery. Focal resections can be very effective. Widespread diffuse pathology can be less effectively treated, though there are exceptions to that, like we talked about TS earlier, or even hemispheric epilepsies in which you do hemispherotomy. Interictals on the other side, the good side, don't preclude you from getting a hemispherotomy. Surgical morbidity and mortality is low. Unexpected neurological consequences of surgery is less than 1 to 2%. Mortality is less than 1%. Even young children. I've done hemispherectomy in 28-day-old children, 1-month-old, 3-month-old, 6-month-old children. I would argue that that is actually the best time to do a hemispherectomy. We have a series of over 20 kids that we did as infants at the University of Washington. Hopefully that'll be published in the next year, if I can get my fellow from last year to please finish that paper. I wish he was on here so I could harass him about it, because the data is all there. And what you'll see is that the morbidity is no different than it is in older children, and the recovery is just astronomical. These are the kids that, so like most of the times after hemispherectomy, there's flaccid hemiparesis postoperatively in the expected distribution from a hemispherotomy. Infants are the only ones other than MCA infarcts in which I've seen kids moving their contralateral side within a week of surgery. It's pretty remarkable. And developmental quotients can improve motor performance, behavioral attention, IQ scores, caregiver needs get lower, social adaptations better, better school performance, better feelings about themselves, just more success in life. Quality of life in general is higher after epilepsy surgery. It's really significant the first 6 months. And there's a really cool study that showed that age-matched cohorts, they can actually reach the quality of life of age-matched non-epilepsy cohorts within 3 years, which is really, really cool. And it's very cost-effective. The lifetime of anti-seizure medicines is much more expensive than successful epilepsy surgery. I will end there and see if you guys have any questions. I can see that I have stunned everybody. Yeah.
Hey, Jay, great overview of all things epilepsy surgery. One of the big challenges and certainly frustrations for us as providers and for families, on the journey of epilepsy, is that we only consider children for surgery when they've been determined to be medically intractable. So traditionally, as you've pointed out, well, 2 drugs, and if you're lesional, 1 drug. But the analogy with brain tumors would be like, well, we're only going to take the brain tumor out if you fail chemotherapy and radiation therapy first, which is kind of ridiculous. We've been hopeful that some of our pharmacogenetics and genomics would have done a better job of anticipating or predicting who's going to be medically intractable before we even start a drug. But I'm looking forward to the day when we don't have to do drug trials to determine who is a good candidate for surgery.
I think you're absolutely spot on for many reasons. I think that there are certainly biomarkers for intractable epilepsy that we have yet to really figure out how to diagnose non-invasively or minimally invasively, because even the PI3K, mTOR, AKT pathway, which we think is probably in greater than 50 to 60. I didn't get to that because it's like a whole other talk in and of itself, the research piece to this all. But it's probably present in 50 to 60% of resected samples in children with cortical dysplasia, hemimegalencephaly. The only way to diagnose a lot of these kids is through brain tissue analysis, because there's mosaicism and you need deep sequencing to figure out a 5, 6, 7% rate of mosaicism. So there's a lot of work that needs to be done. And Angus, I think to your point, it may be a combination of genetic biomarkers and even electrical or history. And that's where AI is going to be very helpful. If we can impute a variety of different clinical risk factors and identify which of those children are very high risk for intractability at onset, at seizure diagnosis, that's going to be really, really key. And then the other piece to it is the delay in actually labeling medically intractable. So if they're seeing one of our outstanding epileptologists here, whether it's Jordana or Angus or Corwin or Kevin or any of you, you're going to reach that diagnosis of intractability very quickly because your mind's on it. This is what you do, you're experts. but they're seeing a community neurologist who's, seeing sleep medicine 50% of the time, is seeing headache 50% of the time. How long is it going to take them to come to the diagnosis of medically intractable epilepsy? And what is keeping them from referring to you quicker? Is it that they want to hold on to the epilepsy patients? They're afraid of, insidious reduction in their practice? Or is it that they're just not seeing the patients frequently enough that they're seeing this kid once a year? It's going to take them 6 years to try 2 anti-seizure medicines by escalating dose once a year. I think
As
all
a
those.
community neurologist, I would say that's not accurate at all.
Okay.
I think we refer properly to you guys. So that may be true where you were before. I don't think that's true here in Arizona.
Matt, thank you so much for joining in. I would say that in Arizona, you guys have a lot of pediatric neurologists, Matt. Like you guys are very, very well staffed. In Montana, Marcus Wheeler, who is a great, great community neurologist, can only see these kids once a year. And so he's doing the best he can. I didn't mean to suggest it as any kind of, you know, desire to not refer out. I'm just trying to think of what the barriers could be to referring out. So I would ask you, Matt, what do you think the barriers are to referring sooner or aggressively to a pediatric epilepsy center? Because we know from the Harvey et al. Study in 2008 that there's room for improvement where the majority of kids are being diagnosed early in life. In the first 2 to 3 years, the vast majority have their epilepsy onset, but they're not being referred for epilepsy surgery until they're 15 or 16. So, where could we do better? I guess is the question. Like, where would you aim your quality improvement metrics towards?
Yeah, I mean, it's pretty simple. I think you have to educate the community doctors. Not, I don't think here, but I think in other places you have to educate the doctors. That's the same. The other problem is that you hear this from adult doctors more than pediatric doctors. Is that you've kind of taken care of these patients in the community, you kind of grown up with them, whatever, and then they go to the epileptologist, they never come back and see you. And for some doctors, that's like, it's like breaking up is hard to do. It's hard for them. They don't get the patients back, and they don't like that. And that would happen frequently with patients that we would see from the Banner system when I was at PCH. Those patients wouldn't always go back. And I would talk to some of the doctors over there who would say, hey, we don't get our patients back, so we don't like to refer them to you. And so I think that's one thing. Is that the only thing? No. But obviously there's some education that could happen that could be better. But I think a blanket statement that the community doctors are not doing a good job is probably wrong. I've done both. I've been in private practice. I've been in academic practice. I've been back in private practice. So I've kind of seen, I think, a lot of different things. And I will tell you that there are doctors in the community doing a very good job. Very good job. So I think a blanket statement is just unfair.
Yeah, so Matt, I apologize if you took it that way. That wasn't my intention at all. I'm just pointing out where could we do better with lining up diagnosis of intractable epilepsy to referral to a surgical center. So I apologize if that came across as a criticism of community. It was not my intention at all. I agree. You guys are seeing the lion's share of neurology patients by far and away. So unless there's alignment there, we'll never get to the care of the children that we need to get to. So thank you for bringing that up. And again, for correcting me if I said something that was incorrect.
Yeah, and the other thing is that the access to the epileptologist is just ridiculous. Like when I was there was a time when my wait list was like 13 months. I mean, the most it ever is now is maybe like 2 months. And granted, I'm not doing epilepsy, anymore, but it is like, that's ridiculous. I mean, that's just completely stupid. And if you have your own practice and you have your own business, you can just see how completely unsustainable that is. So it's the access that needs to be improved somehow. And I don't know how you guys want to handle that. It's quite obvious to me what the answer is, but I mean, how you guys want to handle that is probably different than the way, keep everybody happy and keep everybody, okay. But it's the access that's at least part of the problem.
Well, do you think there's an overall workforce shortage in pediatric neurology in general? Do you think we're training enough?
No, I think the problem is that you have to have people who are willing to work. And this is not what I am saying has nothing to do with any of the epileptologists PCH. Because when I was there, unless things have changed, we all worked crazy hard. Not that I think all the neurologists at PCH work really hard, but we worked really hard. I don't think we could have worked any harder. I think we all, on our clinic weeks, we're doing 10 sessions a week. But the bottom line is that you have to have people who are willing to work hard, and not everybody is. And people that have these kind of, quasi hybrid academic jobs, like seeing, clinic, 3 days a week or whatever, that's not going to work. I mean, you have to have people that are willing to work really hard, and you also have to have the staff to do it. So I think it's a lot of things that are mythical when you work at a place that, doesn't have an unlimited budget. So I think it's just a question of working hard and finding people that are willing to do the work. I think it's as simple as that.
I really appreciate you joining. I do. I think that your perspective is super, super helpful. So thank you for your
Hey,
comment.
Jay, it's Neil. I'll just make a couple of points, and thanks, Matt, and kind of just to follow up a little on Matt. Right now the wait list for pediatric neurology is 3,000 patients. We have 28 roughly neurologists. So to your point, are we short of neurologists? I think the question is absolutely. I think to Matt's point, again, if we go into advanced academic neurology, it's different to what people do in private practice, obviously. And so there's this huge tension between the ability to do research teaching, the so-called tripartite mission. But I would say that there are mechanisms in place, and we've tried and we've implemented to try and help this issue. So for example, we have used electronic records to identify patients onto medications, because there's a significant number of us, meaning general child neurologists, that are following epilepsy patients for other reasons in general, not usually pure epilepsy, that are on 2 or more medications, and they now identify. Jordana monitors a dashboard, and they get referred to the epileptologists. But as Corwin said, that the epilepsy wait is sort of 6 months plus. It's a very complicated problem, because a lot of what I would call basic primary epilepsy is referred in and not managed any longer by primary care providers who used to manage it. So it's a very, very complicated discussion. I don't think it's any one thing, but certainly access is an incredibly important issue. Identifying the right patient. I can tell you, we have we follow roughly 5,000 patients in a 2-year cycle in epilepsy here. The number of surgeries we do, based on the discussions we just had, nowhere reflects anything like that sort of volume. So either we've got a very skewed population, or the patients aren't being referred appropriately for epilepsy. I'm actually busy looking right now at the referrals from our own epileptologists for surgery. And again, unless the practices are somewhat distorted, the volumes there are also not very big. So I think it's a problem across a lot of different areas.
Are there any other questions I can answer about surgical epilepsy technique, strategy? I'm very passionate, though, Matt, to your very, I thought, thoughtful comments about how do we get more kids, we're diagnosed early with intractable epilepsy, and there's so many barriers. There's so many barriers, but it's through thoughtful discussion that we can take them down. So thank you. All right. Well, I guess we're over time, so I appreciate everyone's attention and input and questions, and I hope you guys have a great day.